You have exactly 13 minutes plus, let's say, 1 or 2 questions, and then we will go on because we will have the possibility to ask more questions at the end of the session, in which we have 25 minutes for discussion. It's my pleasure to introduce the first speaker, which is Professor Gerhard Christofori. And his talk will be about transcription factors, miRNA, and long non-coding RNAs regulating EMT and cancer metastasis, here from the University of Basel. Thank you.
Thank you very much. Maybe I can have my first slide.
No, not yet.
So as you can see, and I apologize to those who came for the title of my talk, faced by the short time to present, I have changed my title, and I promise you a short and hopefully sweet story on a burning question actually of clinical routine, which is resistance development in cancer therapy. So I start by setting the stage. You all are aware of the fact that cancer originates by multiple stages. And one of the stages that is very important in tumor development, in carcinogenesis, is actually the induction of tumor angiogenesis, and that is the formation of new blood vessels from pre-existing blood vessels. As you know, when a nodule grows, when tumor cells are proliferating, they form a neoplastic nodule, but they can only reach a certain size, and then they cannot grow beyond this size because they grow away from the blood vessels and they lack oxygen and nutrition, and they will actually undergo apoptosis. So tumor cells and cancers have found ways to induce the formation of new blood vessels, the process of tumor angiogenesis, and these blood vessels then grow with the tumor, expand with the tumor, and provide the tumor with nutrition, with oxygen, with glucose, and also to get rid of debris that has to be transported away. And after the discovery of this tumor angiogenic process during the multi-stage tumor progression pathway, it has been realized, or it has been found, that this is induced by growth factors, so-called angiogenic growth factors, and one of them is indicating here is vascular endothelial growth factor, or VEGF. It has been found that this is essentially the prototype and most prominent and important angiogenic factor that is active during tumor angiogenesis and induces the formation of blood vessels during tumor growth. But there are also many other growth factors that seem to be important and contribute to angiogenic therapy, and that will be important in a few minutes. So after this discovery, of course, people have immediately turned to approaches to interfere with this tumor angiogenic process by either sequestering the angiogenic factors like VEGF, or by inhibiting the growth factor receptors like VEGF receptors or FGF receptors, by small molecule compounds, or also by, for example, immunonanoparticles, as we have done in our lab, by targeting, for example, immunoliposomes with antibodies against VEGF receptor 2 and VEGF receptor 3. And these immunoliposomes are loaded with doxorubicin, so a classical chemotherapy. And you can see that this works very efficiently in preclinical mouse models. We have tested that in a variety of transplantation, but also transgenic mouse models of different cancer types. You can also see what you observe after this therapy. So in a control-treated tumor, what you can see is that there are small capillaries, and that these capillaries are all in a certain distance to the tumor cells. So the diffusion constant for oxygen is perfect. Tumor cells get oxygen and they can still proliferate. Whereas when we repress the formation of blood vessels, the tumor cells are not provided with oxygen and nutrition, and you can see these are all apoptosing cells that are shrinking and have pycnotic nuclei and are apoptosing. And the tumor essentially regresses and has a necrotic area. However, when this has been transferred into the clinics, and this is now routine in the clinics, for example, using Avastin, or bevacizumab as it is called, is a humanized anti-VEGF antibody produced here in Basel by Roche, but developed by Genentech. And it's, for example, used in colorectal cancer. And you can see that the progression-free survival, there's a benefit for the patients, but the patients are relapsing, they come back, and essentially they succumb to the disease. So there's an initial effect, but then the tumors come back, they become resistant to this actually very efficient therapy, and the tumors relapse and still grow. So it has been found subsequently by many laboratories and nicely summarized in this review by Gabriele Burgers and Doug Hanahan, that when we inhibit, for example, this anti-VEGF therapy, with the anti-VEGF therapy, so we inhibit the most important angiogenic factor, that the tumors first respond, but then relapse by switching to other pro-angiogenic factors. Of course, there's also intrinsic resistance, that the tumors do not react in the first place because, for example, they do not use VEGF in the first place. Anyway, so what we thought, and this is what, when I say we, is a PhD student Ruben Bill, Laura Pisarski, and the postdoc Ernesta Facciani. What we thought is that we go one step ahead and use multikinase inhibitors which would in one hit repress essentially all the signaling pathways that are known to be pro-angiogenic, which include VEGF receptors, FGF receptors, PDGF receptors, and also SRC family kinases. These multikinase inhibitors are actually now being approved and coming slowly into the clinics. So what we found is, or the setup of the experiment is now also to treat the tumors when they are starting to grow. So there will be a control-treated cohort, there will be the treated cohort, and we will take at different time points samples of the mouse models, of the tumors growing in the mouse models, and then analyze them and see what happens during tumor progression. And what we saw to our surprise is that with the multikinase inhibitor, that the blood vessel density was repressed after a short-term period of treatment, but also in the tumors that relapsed, that came back. So these tumors grew without active angiogenesis. You can see there is no difference in blood vessel density, and you can also appreciate, compared to the control-treated tumors, that there are much less vessels in the tumors. So what has happened? Also, hypoxia is increased in these tumors. So these tumors really suffer from a lack of oxygen. They are hypoxic, as stained here by hypoxia staining. So what we did is we took samples from the control-treated tumors, from tumors that responded to the therapy, and to the tumors that have regrown, that have started to regrow again. And we, by FACS sorting, isolated tumor cells and endothelial cells, and then analyzed by Affymetrix chip and later by RNA sequencing, changes in gene expression profiling. And I can tell you, when we look at endothelial cells, what we found is that these endothelial cells are still dying. So the therapy actually works, but the tumor grows anyway in the presence of a working anti-angiogenic therapy. But when we looked at the tumor cells, what we found that the tumor cells have changed dramatically. And what they show is a dramatic shift in metabolism. What we call, they have undergone a glycolytic shift. They have switched to glycolysis. And now you would say, okay, but this is the Warburg effect as we know it in tumors, that tumors use glycolysis in the presence of oxygen. But this is now, of course, what we call a reverse Warburg. It's in the absence of oxygen. So they use glycolysis. What we did in the next step is now there is a glycolysis inhibitor called 3PO, developed by a small company in California, which inhibits actually a metabolic agonist of glycolysis, so it's a bit more complicated. But to cut the story short, when we treat now the mice with the angiogenic inhibitor, nintedanib, this multikinase inhibitor, but in addition also inhibit glycolysis, you can see we can essentially stop the regrowth of the tumor. We can prevent resistance development in these tumors. So there's a colleague in Brussels, his name is Pierre Sanvon, and he has proposed a few years ago that in tumors, when they become hypoxic, there is what he calls metabolic symbiosis. And that means that tumor cells that are close to a blood vessel, which is still there, would actually not use the glucose, they let it go through, and the tumors that would not get the oxygen and the tumor cells not getting the oxygen because oxygen cannot diffuse as far, they would use the oxygen, they would use the glucose and use anaerobic glycolysis and produce lactate. The lactate is then exported by a monocarboxylate transporter MCT4 and goes to the cancer cell that is close to the vessel that can use the oxygen, and the lactate is then used for oxidative phosphorylation for energy generation. And the lactate is imported by MCT1. So the question was, do we see that also in our anti-angiogenic treated tumors? And it's a bit complicated, but you can see here that MCT4 is actually expressed in the hypoxic areas. So it looks like that we have this kind of metabolic symbiosis, that some cells that are hypoxic show a different gene expression profile than the cells that are not hypoxic. So what we did here now is we used CRISPR technology to knock out MCT4 in the cancer cells and now transplant them into the mice. And you can see that again, when we now take out the transport of lactate, we can repress the resistance development in these tumors, the relapse of these tumors. And this essentially makes MCT4 and also MCT1 a novel drug target. And this is actually true also because that pharmaceutical companies are now starting to produce inhibitors for these importers and exporters. So to summarize, what we found is that when we treat tumors with an anti-angiogenic therapy that is very effective, that is still working even after a long period of treatment, the tumors undergo a metabolic switch. They go into metabolic symbiosis. So the tumor cells away from the blood vessel will use glucose and produce lactate. Lactate is exported by MCT4, imported by MCT1 in the cancer cell that is close to the blood vessel, and this will use the oxygen also to produce ATP. And this is essentially, and we can, a symbiotic collaboration of these cancer cells in the tumors. And when we interfere with MCT4 expression by knockout or by knockdown, or if we inhibit glycolysis or also use rapamycin, an mTOR inhibitor, which is also a glycolysis inhibitor, then the system collapses and the tumors cannot grow anymore. So I would like to collaborate the people involved in this work. I have mentioned the three main players in my laboratory, but we have collaborated also with Christoph Hess and Sarah Dimelo at the Department of Biomedicine here at the University of Basel on the metabolic analysis, and also on metabolomic analysis with Nicolas Zamboni's lab at the ETH in Zurich. So I thank you for your attention, and I'm happy to take questions.
Thank you very much. And we have time for one question. Jesse? Wait for the microphone, please.
Okay. I want to congratulate you first for the very nice lecture, but more so for the fact of bringing back metabolism and metabolome to our attention, because I believe that that's part of the tumor therapy was completely neglected for many years, and I think without really getting it involved in our treatment, we are not going to get really what we want to achieve. I think that's fascinating, and I'll show a little bit of slides also related to metabolism, but I think it's really critical to understand the tumor metabolism in order to try to beat the tumor.
Yes. No, thank you very much. I agree with you, and this is the tip of the iceberg, of course. We now know also by working on mTOR signaling, for example, and by the work of many, many people in the field, that, for example, amino acid metabolism has been completely underestimated, and this is very important in carcinogenesis, and of course fatty acid metabolism. Okay.
Thank you very much. There will be time at the end of this session for more questions. The next